which I'll stick up in a minute. Purposes of the session really is to introduce myself, let you know how to get hold of me if you need me, let you know what I can do, and then talk about stuff that happens in ED as far as I understand it. Really, what I think is the most important things for you to all know about the alcohol withdrawal treatment pathway, and what happens next, and this, that, and the other. Feel free to ask any questions either by voice or in the chat. Sarah's going to keep an eye on the chat and see if anything comes up. Point me back to it. If anything doesn't make sense, then that's worth bringing up as well. Really happy to re-explain stuff. So yes, I started in the hospital in April. I think you've had alcohol liaison here since more than 2 years ago, but my predecessor left, I think, late last year, so there was no handover. There was obviously a gap in service, and probably for a while everyone got used to them not being an alcohol liaison nurse. So I'm on bleak. I work Monday to, well, I've got 4 long days between Monday and Friday. My days off is usually a Tuesday or Thursday, occasionally a Friday, occasionally a Monday it will be, and that's according to the service need and my needs as well. But most of the time I'll be here on a Monday and a Friday, which are probably the best days for picking up new referrals. I'm on Bleak 182, extension 6686, and my email address is available should you need it. If you see someone out of hours and you think it's worth me chasing them up, if they're in the hospital, I'll see them in person. If they've been discharged and you know that they're not engaged with services or might benefit from a call, then I'm happy to try calling them. I won't try loads of times, and very often people don't answer the phone, but really what they should be doing is going to their respective community drug and alcohol services if they're ready to do it. Having said that, I appreciate that the situation that the hospital is in is mostly that people aren't here because they excuse me, people aren't here because they want to address their drug or alcohol problems. They're here for a other reason, and it just is coincidental that they get some kind of contact from us. Now, let me think. I'm trying to share the screen. I might get hang on. What? Okay, include computer sound. There you go. I'm trying to share the screen. What? Now I do this.
Yep.
And then I open the thing, right?
And then they are open. Yep.
Yeah. Okay. So here's my alcohol presentation. These slides are mostly to keep me on track, really, but they will be available should you wish to refer back to them. Most of the content comes from the alcohol withdrawal guideline, which was released a couple of months ago, actually, rewritten, I think, mostly by Dr. Cowan, who's a gastroenterologist, and probably some input from elsewhere. I have noticed with it already that it's got the wrong extension number and bleed number for me in it, so I'll be trying to get that changed. Anyway, what I want to do is talk about my job. Kind of already, well, I'll do some more of that in a minute. Talk about identifying problem drinking, raise your awareness of the guidelines, and give you an overview really of alcohol dependence and withdrawal. So background is on here about the costs to the NHS of alcohol and how much of that is in hospital costs. What also I think is particularly interesting is that we know this when I used to work my background is I used to work in community drug and alcohol services for like 20 years, and I've been in the hospital since April, so I know a lot about the patients, the clientele, whatever you want to call them, but I don't know much about hospital working, but I'm learning about that pretty rapidly as we go along. In community drug and alcohol treatment services, people with alcohol problems are massively underrepresented. So it says there 10% of people needing treatment actually access services. You compare that to intravenous drug users, which is something in the region of 60 or 70% of those who need treatment are accessing treatment, then there's clearly quite a bit of work to do. Presentations at hospitals where people are, coincidentally presenting as drug and alcohol dependent have proved to be an opportunity to access this client group. But the important thing is to have somebody like me in the hospital, and then it's also important to have somebody identifying the people and referring them to me, because see everyone every day and find out. So yeah, the purpose of the job really for me is number one is making sure that people who are identified as alcohol dependent or having alcohol problems are assessed for treatment whilst they're here because of the risks of alcohol withdrawal. And the second bit of the job is me coming along and trying to reflect to them about their situation. They're sober for a few days, which is quite rare for some of the people who come through. And this is an opportunity to reflect on why they're in hospital. Is that related to the alcohol? Is the alcohol a problem? And try and motivate them then to engaging with community services. People with alcohol problems present more frequently to hospital, and when they come into hospital, they stay there for longer. And that, I guess, is the basis of the costs that you see at the top of that slide there. Is that all right? Good. Now I want to talk about screening, which I did speak about earlier. So you'll have to help me. I can't find the document along here. Is it one of these? Is this one? Okay, so there's a one of the, this is the alcohol withdrawal management, and I found out earlier that screening for alcohol dependent or for alcohol misuse isn't routine in the hospital. Now that is something that I kind of assumed was the case, and I know it's not the case in many hospitals that everyone who comes in gets screened. But just to bring your attention to this very simple tool, if I can find it. Here we go. I just went past it. It's a 3-question screening tool. It's called the Audit C, which is Alcohol Use Disorders Identification Test. I'm not sure what the C stands for actually, but the full audit is 8 questions. This is a 3-question version. This page you see here is in the hospital ward admission booklet, but I know that you don't use that in the emergency department. I'm just showing it to you for your information really, and as a screening tool that if you chose to, you could pick up, and if it was decided that it was something people wanted, I'd very happily do a very, very simple, straightforward training session on it. 3 questions: how often do you drink? How much do you drink? How often do you drink more than a certain amount? Those are the recommended, kind of daily limits. And scores down the side here indicates what to do. And if everyone were screened, then a lot of them would be referred to me, even though that bleeps the right number, but the extension number is wrong. Okay, so that's very, very simple, brief alcohol screening. What you're identifying is the level of alcohol-related risk, and the alcohol-related risk is about the risk of bad, any kind of negative outcome from drinking. So lower risk, that means it's unlikely for something bad to happen. Increasing, more likely, higher, etc., etc. And that risk really is a coverall. So sometimes people get drunk and they argue. Sometimes people get drunk and they fail to go to work the following day. Sometimes people get drunk a lot and they run the risk of developing organic damage, liver damage or whatever. And sometimes people drink a lot and they run the risk of developing alcohol dependence. That's right, sorry. And certainly the more frequently you do something, the less likely you are to do an alternative, which I suppose is a kind of a slight partial definition of dependence anyway. That all right so far? So we're trying to think about the emergency department and what you do here. There's from working in community drug and alcohol services, there are 2 main kind of categories of specifically drug and alcohol related emergency that is a medical emergency, and those are overdose, which is most often associated with opiates and benzodiazepines, and other drugs. However, the biggest cause of fatal toxicity, and this is from coroner's reports and analyses, is the combination of alcohol, opiates, and benzodiazepines. The 3 of those presents people the highest risk of fatal overdose. So that's one of the things that people are at risk of, and the other is alcohol withdrawal. So lots of other drugs have withdrawal syndromes attached to them. Lots of other drugs you can become physically dependent to, but opiates, the withdrawal is very unpleasant, not dangerous in and of itself, although people might put themselves at risk when they're withdrawing from opiates. Alcohol withdrawal, however, like benzodiazepine withdrawal and withdrawal from GBL, is actually dangerous to the person, and this is because of the mechanism of action and how the withdrawals kind of manifest, if you like. So thinking about that and relating it to the emergency department, if you know someone is intoxicated when they come in, or you think that they're a very heavy drinker, then an assessment of their risk of alcohol withdrawal needs to be made. Now, I understand this is mostly made by the admitting doctor, and I am doing some bits of training with junior doctors in various parts of the hospital. But when looking at an assessment of the risk of alcohol withdrawal, everything on this slide is pertinent. So, you know, how much they drink, how often, what time of day do they get withdrawals when they haven't drunk, etc., etc., etc. When someone presents here, if they're intoxicated, okay, you know you've got some time to wait until they may start withdrawing as they become less intoxicated. But if they're sober and they tell you that they've been drinking dependently, or you know that they're a dependent drinker, then it's really important to know how long since the last drink, and it's also really important to start treating them as soon as possible, as soon as withdrawals manifest. The main tool that you will use for all of this stuff is the CWAR. Again, I forget what that initialism stands for, but it's the accepted and standardized and used alcohol withdrawal scale. It's important to note, like everything I say is important to note, isn't it? It's important to note that individually, all of the symptoms on that list aren't necessarily alcohol withdrawal. So if you think about profuse sweating, that can be caused by many things. Tremors can be caused by many other things. Something to do with blood sugars can make you, if it's high or low, can make you tremor. Confusion can be caused by many things, and so on and so forth. What I would say is, it's important if you know that someone's a drinker to use this tool. And the reason the tool covers all those areas is because withdrawals manifest differently amongst the population. Different people get different symptoms at different times of their withdrawal. But what you're looking at is a syndrome, really, rather than an individual symptom. So if you've got a cluster of those symptoms and you know that someone's a drinker, then it's pretty highly likely that what they're doing is withdrawing from alcohol. I put other drugs in capital letters at the bottom there, particularly benzodiazepines. Benzodiazepine withdrawal is of itself is worse generally and longer lasting rather than alcohol withdrawal. It's also that the syndrome is exactly the same, and if someone is benzo dependent and a drinker, then they'll need big doses of both, way above probably normal BNF limits, etc. So okay, daily unit intake at the top there, really quite important. Units, most people know how many units what their chosen drinks contain if they're buying it in cans or bottles, because it's printed on there. People who drink in pubs won't necessarily know how many units they're drinking. A unit of alcohol is an arbitrary measure just used for standardization across different presentations of alcohol, but the way to calculate units is that little equation there. Units equals percentage alcohol by volume multiplied by the volume in litres. So a half-litre can of 5% alcohol by volume lager contains 2.5 units. All right. So what do you do if you've got someone that you know is at risk of alcohol withdrawal? Well, you start doing a CWAR, and you start you get whoever the prescriber is for them. Whether I'm sure there are nurse prescribers in the department, aren't there? I'm sure. Yeah.
Not many, but yes.
Okay, so nurse prescriber or doctor, whoever the clinician is that's responsible for them, you make sure that they've written the chart correctly. Now, according to our policy and standard practice, the chosen benzodiazepine for alcohol withdrawal is chloride epoxide. That's the commonly used one. And according to our withdrawal guidelines, for a CWAR triggered PRN dosing regime, which I'm assuming is the norm in the ED, because people aren't here very long and they're not certainly not here 24 hours or long enough to go onto a regular reducing regime, you would give the doses as per the CWAR score as I've put there. It says in there for if people score 35 or more on the CWAR, which is really, really unusual, at that point you'd probably be wanting to give them as many tranquilizers as they can take. It's in the policy, it says to seek senior review. What's really important with CWAR triggered dosing is that you repeatedly assess the effectiveness of the medication that you're giving someone. And again, this is all in the policy, and I'm sure you're used to dealing with it. And I know that very often, if people come in intoxicated, they will stay here 24 hours. They'll move to CDU, and you'll see them in there, and you'll see these regimes, and so on and so forth. The standard prescribing plan is to get someone on a reducing regime of chloride epoxide as soon as possible. But the first thing you've got to do before you start reducing is stabilize. There's no point reducing the dosage when someone is still using is still actively withdrawing, because what will happen then is the withdrawals will get worse. So a little bit about alcohol withdrawal and how long it lasts and how soon it manifests, and this is why it's, like I say, it's important to keep treating, and very often you'll be giving people increasing doses for the first 48 hours and not reducing until they've got stable on a fixed regular dose and not having any further PRNs, is because alcohol withdrawals get worse with time. The uncomplicated withdrawal generally resolves fairly rapidly, and those are the symptoms you might see. Hallucinosis comes on later and lasts longer. So if you think about someone's not showing any signs for 24 hours and you start reducing the dose of chloride epoxide, their central nervous system will still be not reaching its peak of overworking, if you like, and so they'll be at risk of symptoms worsening. Withdrawal related seizures can happen with it's a broad range, isn't it? But people can have their first seizure as late as 48 hours after their first drink, and if they're not maintained in a relatively withdrawal-free state up until then, these might occur later on. Okay, I wanted to talk a little bit about DTs. DTs is a misunderstood and misused phrase, or what's not even a phrase, is it? Term. And it's fallen in the common parlance. It's fallen into use for people describe themselves as DTing a bit when they're just shaking a little bit in the morning. That's not the same at all. It's also different from just hallucinosis, in as much as you get all the fevers, the agitation, the tachycardia, the dehydration, and these are the further symptoms. So hallucinosis in itself isn't dangerous. DTs can be dangerous, can be fatal, very rarely so, but it can be so. Now, I'll forget the numbers. They're probably too depressing to read, but there have been numbers of people who have died of the DTs whilst being treated for the DT. So it's really tricky to treat, or can be tricky to treat. The guidelines for prescribing for DTs are all in the withdrawal management guideline that I've mentioned, and it writes about using haloperidol and lorazepam. As a rule of thumb, if you are in the situation that you're nursing somebody with the DTs and it's unclear as to whether to give them lorazepam or haloperidol, lorazepam for agitation, haloperidol for loss of touch with reality, psychosis, whatever, would be my advice, or both. They're in hospital after all, so it's probably better to knock them out a bit than to leave them potentially getting worse. What's next? Okay, so I've talked a little bit about the prescribing, the symptom triggered, and the standard regime. All of this is covered in the appendices of the withdrawal policy. Generally, if someone comes in and you're doing a CWAR triggered PRN dosing regime, that'll be done for 24 hours. Then you add up the total of chloride epoxide that's been given, divided by 4, and that is their 4 standard doses for the next days. when I see and assess people, I always say, please don't reduce until they've been 24 hours without requiring additional doses for the reasons I've already mentioned. And it's important that someone on a standard regime has PRN doses available if they need them, and CYs are still completed. If they're using a lot of additional doses over the first 24 hours of their standard regime, then those shouldn't be reduced, but it may even need to be notched up one to the next level the following day, if you see what I mean. Now, the BNF and I think our guideline says that the maximum dose of chloride epoxide for alcohol withdrawal within 24-hour period is 250 milligrams. And that could be interpreted to mean, oh, well, I better slow down then, or I better spread the doses out a bit more. Maybe they can rattle a little bit and, we'll get through without going over the maximum amount. But that's not best practice. Best practice is to keep giving and to just get a sooner medical review for somebody if they're needing that much chloride epoxide. It may be that they then get some, lorazepam added, whether or not they're agitated, just to kind of top up their dosages. But the prescribing regimes in the policy are pretty clear on all this sort of stuff, and there is support from some of the specialists, gastroenterologists, about prescribing for alcohol withdrawal for other medics. Some of the medics around the wards are very experienced in doing this, and both myself and Dr. Cowan are doing bits of training with other doctors about this. Okay, good. The other thing that's given as standard in hospital is vitamins, particularly Pabranex, vitamin B, and that's to prevent or treat Wernicke's encephalopathy, which is it's a condition created by thiamine deficiency that, if left untreated, or repeatedly untreated, can lead to Korsakoff's. It's called Korsakoff psychosis now, and I guess that's just using psychosis as a meaning loss of touch with reality. Also known as Korsakoff syndrome, alcohol-related brain damage, dementia, this, that, and the other. Anyway, it is irreversible when it gets to Korsakoff. Wernicke's, on the other hand, is reversible. The guidelines again will tell you who's at risk. I would say pretty much anyone in alcohol withdrawal is at risk, and I know there's very, very good practice here in terms of routinely giving intravenous Pabranex to people who are going through alcohol withdrawal. Again, the dosages are all written in the guidelines. Anyone at risk, give it for 3 days. Anyone who's got any of the symptoms, which are on the next slide, should have it for 5 days, and then review. And if it's if the symptoms are improving, and it can be continued for longer than 5 days if necessary. Excessive vitamin dosing isn't going to do anybody any harm, and it's kind of a belt and braces approach. Is that all okay? Yeah, good. Here we go. Those are the that's the vitamin B prescribing as per the guidelines. Interestingly, here it says all thiamine 100 milligrams TDS. In community services, we give and recommend 200 milligrams TDS. Or they rather, it's not we anymore, I've gone. With regard to admitting people to hospital, as it says here, people aren't routinely admitted just for the alcohol detox, but if they've got something else they need to be admitted for, then it will continue. If someone's admitted for more than a couple of days, then they're pretty much, I'm pretty much bound to hear about them and bound to see them unless someone leave or something like that. There's complications and risks that may lead to admission. So when you think about people who are self-neglecting, street dwelling, have coexisting mental health conditions, etc., safeguarding vulnerabilities, they're likely to be admitted for kind of social needs and reviews of their packages to get them out. But, otherwise people just keep coming back and getting worse and being at further risk, etc. So it's necessary that we do this. discharged from hospital after an admission, if I've seen someone during an admission and they've completed their withdrawal program, I will always see them, talk to them about, referring them to their